been an independent prognostic factor for many diseases, including Hodgkin's disease. This has been demonstrated in several trials and also in population-based studies. And older patients account for 20% of Hodgkin lymphoma patients. We'll see that in Brazil, for example, there is a smaller number of cases. I'll show you in the next slide. And this population is a very heterogeneous population. We have older patients that are very fit, and also we have patients that are very frail. This is our Brazilian data from 5 reference centers from the state of São Paulo. This was a retrospective study from 1990 to 2000, and we evaluated 1,025 lymphomas, and we see that older patients correspond to 8% of our Hodgkin's lymphomas patients. This data was dated from 15 years ago, but maybe now that the life expectancy has increased in Brazil, maybe we can see a little increase in this age group. This is SEER data from the United States showing that the survival of Hodgkin lymphomas has increased in the last decades. From the first this evaluation in 1984 and now 2004. The survival has increased, but patients with more than 6 years old has a lower survival. And even besides the increase in the survival of these patients, when we do a method compared with the normal population, still those patients, they have an inferior survival. And what would be the cause of this prognosis, this poor prognosis? There are several reasons. One of them is biological reasons. And this population frequently has more EBV positive case and more B symptoms. Sometimes the doctors are not so motivated or treat less aggressive these patients. Comorbidities is an important cause for this poor outcome. Many patients have cardiac disease, pulmonary disease, diabetes, hypertension. All of these, they may affect organs, and this increases the toxicity to conventional chemotherapy. And of course, the treatment-related mortality is worse. And many regimens that we use to treat Hodgkin's lymphomas includes bleomycin, and those patients has an increased risk of presenting lung toxicity. This is a publication from the German groups. In this paper, they evaluated 2 trials for early-stage Hodgkin lymphoma that were treated with 4 cycles of ABVD. And what they observed that in older patients, these patients had more grades 3 and 4 toxicities. In around 14% of patients did not comply with the protocol. They have delay due to toxicity. The delay of treatment was practically double the time when compared with older patients or with younger patients. They had an increased rate of treatment-related mortality, and also the complete remission rate was inferior to compared to the younger group. This is just to show that the protocol adherence was inferior in patients older than 60. And this reflects, of course, in overall and progression-free survival. We can see here the older patients in yellow and in blue. So this is the data for this first publication. In this another review, they evaluated patients from the age 10 and age 13 trials. So it was 287 patients older than 60, and patients were treated or with 2 cycles of ABVD, 2 cycles of ABV that submitted bleomycin, or 4 cycles of ABVD. They show that 2 cycles of ABVD or AVD are almost the same. They don't have different toxicities. However, patients that were treated with 4 cycles of ABVD, they presented more toxicity, and 10% of these patients presented bleomycin lung toxicity. 3 of the 7 patients have died of complications related to this toxicity. And this is the termination of the protocol. 18% of patients that was treated with 4 cycles of ABVD, they had an early termination, and the reason for that was toxicity. This was not seen in the other arms. So the survival was not significant among the arms, showing that 2 cycles are more safe than 4 cycles. Besides the conventional chemotherapy, other drugs has been explored in the context of treatment of Hodgkin lymphoma. It's just an overview. I'm not going to talk about all of them. One of them is brentuximab vedotin. This has been studied in a phase 2 trial, showing the next slides. Other drugs, the histone deacetylase inhibitors, mTOR inhibitors, and lenalidomide has also been studied. So brentuximab is a CD30-directed antibody conjugated to an agent that's a microtube disrupting agent. This has been studied first in a phase 2 trial that evaluated brentuximab in patients with Hodgkin's and non-Hodgkin's lymphomas. And in the sub-analysis of this population, they observed an objective response in 56% of the older patients. However, these patients had a higher rate of toxicities. The more frequent was anemia, the peripheral sensory neuropathy, fatigue, and when we compare to younger patients. More recently, a phase 2 trial evaluating brentuximab in first line for older patients has been published. They evaluated 26 patients, and in this trial, the overall response rate was 92%, and the same toxicities were observed. The most frequent was the neuropathy, peripheral neuropathy, fatigue and nausea, and anemia too. The neurologic events were more frequent in patients that has other risks like diabetes and hypothyroidism. So the frequencies was higher. So this is their tumor reduction showed in this plot, showing that most of the patients reached a complete response. However, the duration of this response, the median progression-free survival was 10 months for all patients and 11 months for the patients that have reached the complete response here. And there's another drug that has been explored in Hodgkin's treatment. This is a phase 1 trial with a combination of panabinostat plus everolimus in patients with refractory or relapsed Hodgkin lymphomas. Only 13 patients with Hodgkin lymphoma were analyzed in this study. They are represented by this bar here. And we see that some patients have reached complete response, but they have a dose-limiting toxicity. There was thrombocytopenia and other cytopenias as well. This is just to show the response that a Hodgkin patient had before and after 3 months of this combination therapy. So there are some recommendations for treating those patients. One of them is always to evaluate a cardiac and a pulmonary function before chemotherapy. Patients that have some degree of cardiac insufficiency, we could omit the dose of doxorubicin or at least administer only 1 or 2 doses. And for patients who have pulmonary dysfunction, an option is to omit, as I told you before, omit bleomycin. Some centers switch for CHOP regimen. And another recommendation is to avoid G-CSF because this is related to an increased risk of bleomycin-induced toxicity. And they recommend to use full dose of chemotherapy if neutrophil counts are more than 200. So what can we do to improve survival in these patients? It's important to have studies, collaborations, multi-center trials, regimens that are less toxic, and that we have objective criteria to predict those toxicities. And of course, the integration of novel agents may be important to lower the toxicity in this group of patients. And one very important thing is to incorporate the functional status evaluation, because as I told you, we have many different types of older patients. So this may be do a more patient-specific tailored therapy. Thank you.
So again, just a question with the brentuximab. What are your thoughts on that in the front line? I mean, is that going to be one of these that will have a high enough response rate that it might be as a single agent or maybe in combination that, for this population? Because again, I agree with, the adriamycin and the and the bleomycin toxicities can be bad. The problem is we do so well with chemotherapy. It always makes very nervous to ever do less because you go, I'm curing all these patients, don't want to take a chance. So what's your thoughts on the brentuximab?
Yes, I don't have personal experience, but if you analyze the German studies, you see the survival of older patients, they are quite good. And you saw the phase 2 trial of brentuximab. And so I think as a single agent in frontline would not be the best way to go. That's my opinion.
So I would say the same thing. I think the goal with Hodgkin should be cure. And I look at brentuximab as a single agent. It's a palliative drug. Lots of people are very excited, and I think there's reason to be, but keep in mind that is a fancy technology applied to something that was first discovered in 1960, which is that that tubulin agents are among the most active agents for Hodgkin's. It was part of MOP and it's part of ABVD, and what this is a very potent tubulin agent. And if you actually look at some of the earlier trials using vincristine alone, or a trial we did in auto transplant failures with Hodgkin's that we published around 1998, the single agent activity of Velban in transplant failures was like 70%. And so, I think it's a very good agent, but this is not the one. This is not a prutinib. This is a vinca alkaloid, that is very potent. That's put on a targeting monoclonal.
But do you think it has a potential, though, if you add it to, a couple other, you do a combination with it that may reduce some of the toxicity? Because again, I think, the issue is both the, acute and the late toxicities of ABVD. ABVD, I generally, even older patients, was able to deliver relatively, efficiently and get them through. Sometimes, again, it's a late toxicity. I had a young lady who, years later got a viral pneumonia on top of having ABVD, and just her lungs were shot, and you just know it was the issue that she had with the bleomycin. But I never took bleomycin out because you never want to risk not curing them. So that's kind of my thought, is it not as a single agent, but could it reduce some of the other toxicity like bleomycin?
Yeah, I mean, there are obviously numbers of studies ongoing now that are taking bleo out, and I think you want to take bleo out. Yeah. And the true contribution of bleo is probably relatively small. I would be very apprehensive about taking doxorubicin out unless you absolutely have to. In every study that ever compared a second generation regimen against MOP, it was the addition of doxorubicin that led to the increased cure rate. And so it is a very critical drug. And one of the things I can say about it is that you get more toxicity when you give dox at higher acute doses. That's why EPOC has lower cardiac toxicity, and that's why ABVD has lower cardiac toxicity than you see with CHOP, because in CHOP you give 50 milligrams per meter squared every 3 weeks. With ABVD you give 25 every 2 weeks. Just the fact that you're giving half the dose leads to lower peak levels, and you've got lower cardiac toxicity.
A clinical trial has shown that after 2 cycles of ABVD, if patients achieve negative PET scan, it's the same to go on with ABVD or AVD. So Maybe that's a strategy for.
Yeah, yeah, that makes sense. Yeah, it's a nasty one though. Just getting rid of it outright isn't good. They've tried that and that's failed.